So yoga.
Yes, sir.
Coming back to uveal melanoma.
Yeah.
So is there any animal model or lab test or any preclinical evidence that this modified drug is effective? Well, what is the evidence?
Yeah, so we certainly have evidence in the test tube that this can work in uveal melanoma. In terms of the mechanisms I showed you about, the on enzymes being removed and so on. We don't have a good animal model, so I don't have animal model data in uveal melanoma, but we do have published animal model data in cutaneous melanoma.
And how about clinical application in some other cancers, like pancreatic cancer or something else? Is there evidence that it's effective for other cancers?
Yes, there is animal model data for pancreatic and lung and actually for multiple cancers. Most of the animal model data has been generated with the drug that we use to treat blood cancer, and we point out that you cannot use that drug to treat a solid tumor cancer. It just doesn't get into a solid tumor cancer in a meaningful way. So the logical way to translate actually very abundant science is with the modified drug that we've developed here using federal funds.
Okay, I've got one question over here.
Dr. McNamara, I'm referring to your slide that showed the immunotherapy drugs against ocular melanoma, and I'm wondering, are they so effective against ocular melanoma with metastasis, or are they just effective against ocular melanoma?
Right. And that's probably a lack of explanation on my part. So what I would say is yes. So in fact, they're exclusively used in spread melanoma. So it's ocular melanoma that is spread to the liver or any other part of the body. So yeah. So we don't use them in the primary treatment. So we don't use them to treat the melanoma that's in the eye. There's other ways to do that through radiotherapy or surgery, and those would all fall into the area of Dr. Singh's expertise. But these drugs are used pretty much exclusively for spread melanoma, although with the caveat of I think they will eventually move into the treatment of people of melanoma after surgery or after their eye has been treated in the adjuvant setting. So saying what therapies can we give to people to decrease the risk of recurrence? Can we prevent that from happening? And I think as we move forward, that will probably become a reality. So I hope that answers your question.
So Mike, what is the clinical benefit of this immunotherapy in your experience? I know it's small and limited number of cases, but what is it that we kind of think? 30%, 3-year progression, or 20%? What number would you see?
Yeah, I try not to give numbers, because the numbers really aren't, I don't think that they exist. But the way I look at it is that there's a few different options. For most people, the drugs probably will work in about 1/3 of patients with very manageable side effects, if really any at all. Now, some of these drugs really, the drugs that target PD-1 are fairly kind in that most people who get them really don't have side effects. There are side effects, they can be bad, but the majority of people don't get them. When you start combining the drugs, or if you look at the CTLA-4 drugs, it's a different story. They work in a different subset of T cells, and the side effect profile is a little bit different. But the bottom line is I tell people, look, I think this is definitely worth a shot, because you've got something that may work for quite a while. And I can't identify who it's going to work in right now. I mean, we don't have a blood test. We don't have a marker that we can use right now that says it's going to work or it's not. I think they're very much worth doing. In my experience, I've treated some people and they've done very well. They're out a couple of years and they've been on treatment. And I've had some people where we've tried them and it didn't seem to help. And so, my experience is kind of what the data would say, which is it's a flip of a coin in a sense if it's going to be beneficial.
About 30% response rate.
Yeah, I think that's accurate.
So Mike, can I ask you, do you have trouble getting it reimbursed, Medicare, insurance?
Yeah, no. You have to use creative documentation. And I'm not going to say anything more than that. No. So technically, yeah. I mean, I think that the indication for ipilimumab right now is for melanoma, and it doesn't specify what subtype. And for pembrolizumab and nivolumab, the PD-1 inhibitors, I have not had trouble getting them, but I would not be surprised if one day I did, because technically they're not approved for use in uveal. But it hasn't been an issue for me. I don't know, there's probably someone out here who can tell a different story. But they are very expensive drugs, and so one of the issues with these drugs, maybe not for eye melanoma, but just in general, is that they appear to be active in many different cancer types, yet they're only approved in a few. And so recently I had a patient with a gastric cancer, where there's some very early data in the clinic that these drugs are beneficial, and we have the drug in our pharmacy. We have it here. We use it for other cancers, and I tried to use it for her, and it couldn't get approved. I just couldn't do it. So we weren't able to do it. And that issue, I think, is going to come up more and more. Because
if I could pay for it, how much would it be? I said, okay, it's not approved.
So these numbers are variable. And when I say them, people look at it like, look at that guy's fancy shoes. He must have got the money directly. It's got nothing to do with me, but what I've heard quoted is that for 4 treatments of Yervoy, it's $100,000. And for pembrolizumab and nivolumab, it's, I think, $20,000 a month for continuous therapy. I think.
Drug companies offering any kind of like
financial incentive?
Or even any kind of discount offered for the patients. I know a lot of treatments that are offered in ophthalmology, retinal specialties, they'll offer some kind of "we'll work with you" program.
They are, but I think and I don't know the specifics, so I probably can't answer this completely accurately.
That nobody can have or afford.
Well, no. So insurance covers it.
Yeah.
No, so
you can afford, you may have it.
Yeah.
Based upon that.
Yeah, no. So that's a very real issue right now, and that's the difference between being approved for an indication and being non. So if you're approved, insurance pays it. Now, why the cost is what the cost is, and that's a whole other topic. And but if it's approved, then it gets paid for. It's when it's not approved that you can run into trouble. And so I haven't had trouble yet getting the drugs paid for by insurance. The times where you do is when the data to support your use of the drug is limited, and the insurances will say, I'm not going to pay for a drug that you don't have good evidence is beneficial. And then when you get into that, it gets very difficult. And the problem with with getting support or something is that the criteria are way too, I don't know if it's low or high, but if you make less than $8,000 a year, they'll help you. But if you make like $10,000 a year, they won't. And these drugs are way too expensive to use those types of criteria. But I haven't found it to be an issue in treating patients with melanoma. It's only when you're using drugs that are off-label, as we say.